Antonio, and I just want to say, welcome everyone. Thank you. I'm honored to have the pleasure to speak to you about this very important topic. I've been in healthcare, as he said, for a number of years. I do have a passion for health disparities. I think a lot of our health disparities, when we're talking about communities of color, particularly African-American communities, lies within the past, our education, and then also to policy, politics, and we'll kind of get into some of that tonight. So I'll go ahead and get started. I kind of did a about me slide, so we'll just kind of brush over that. But the name of the presentation is Generational Trauma, and it's Health Disparities with COVID-19. This one, I did this presentation recently because typically when I give this conversation, I just talk about health disparities in general, because as Antonio said, when I went to school, one of my focuses was on health disparities in African-American women when it comes to breast cancer. So that, again, that has always been a focus of mine. And so then we'll focus tonight specifically on COVID-19, and I'll bring up some of the other health disparities as well. So we'll go ahead and get started. So we'll just kind of skip over that. Usually when I start my presentations, I start out with what I call a box of knowledge. Some people do a circle knowledge. And the reason why I say that is because what will happen is as we grow, as we learn, as we interact in our different cultures, environments, social groups, in school, we have what I call a box of knowledge. And that knowledge is everything that we've learned up until this point. I always tell people, look at your box of knowledge, realize that sometimes when you come to presentations like this, or sometimes when you hear information that you're not familiar with, or maybe it's new, or even that you question, it's considered outside of your box of knowledge. That's okay. It doesn't mean that it's not true. That's when you should be challenged to either go look up that information and make sure that it's accurate. And then also too, as we always know, the magic always happens when you think outside of the box. So it's just a reminder to be open. I'm going to be transparent with you. Sometimes having conversations like this can be difficult, but just remember that information you hear tonight may be brand new. Some people, it could be a little shocking. And some people may reject it because, again, it could just be the nature of the information. But again, anything that I talk to you about, I challenge you to go look it up. But I always like to kind of go over that when I get started. One thing that Martin Luther King said was that of all the forms of inequality, injustice in health is the most shocking and the most inhumane. He said that as he spoke in 1965 on the Selma to Montgomery March. So I just wanted you to think about that, because again, that was said in 1965, which has been approximately almost 60 years ago. So our conversation is on health disparities. So what are health disparities? Health disparities are preventable differences in the burden of disease, injury, violence, or opportunities to achieve optimal health that are experienced by socially disadvantaged populations. Health disparities are inequitable and are directly related to the historical and current unequal distribution of social, political, economic, and environmental resources. So what are some of the risk factors for health disparities? If you go to any reputable website, you're going to find poverty, environmental threats, inadequate access to healthcare, individual and behavioral factors, and you're going to also find educational inequalities. But the question becomes, what's missing? So if we know that these resources are, again, part of a current unequal distribution of social, political, economic, and environmental resources, what is missing from from the list of risk factors? And this is where I kind of get into this slide here. So a lot of times, of course, if I'm taking care of patients and I'm seeing them in the office, I don't have an hour to go through 400 years. And honestly, it'd take well more than an hour to go through 400 years here. But when you're giving lectures like this, I like to talk about why do we have the health disparities that we have? A lot of people say, well, it's because you don't eat right, you're overweight, culturally, it could be the diet, and all of those things may be true, but the biggest piece that's missing from that is the historical references to why we got there. So when you think about it, 1619, you had some 20-odd slaves arrived in the US, and we're about 401 years from that. So the question is, how many generations is that? And what can happen in a generation? If you look in any sociology book, it'll tell you it takes about 3 to 4 generations before you kind of lose what you've known to be your culture. So you have to think, if you had people that arrived in 1619, they were not allowed to speak their own language. They were not allowed to read, write. They were not allowed to share their native language with their children. What has been lost in those 20 generations? And so I just kind of brought out some of the key years, just the fact that, okay, at 1800, at that point, we're 9 generations in. U.S. had just been formed in 1776. Then 1865, you have the end of the Civil Rights War, Reconstruction begins. And I put this in here to remind people that Reconstruction only lasted 12 years. So Reconstruction did not even last a full generation, because when I do my slides, I consider 20 years approximately 1 generation. So Reconstruction was cut short. And after Reconstruction, we kind of went into Jim Crow, sharecropping, and then now we're proceeded to almost another 100 years, which was approximately about 88 more years before we got to Brown versus Board, Civil Rights Movement, your Voting Rights Act. And by this time, we're 17 generations in, right? And so this is at the opportunity where they say, okay, we're gonna pass laws, we're gonna let you vote, we're gonna let you go to school, and things of those natures. But we do know, even though a lot of those laws were passed 64, 65, 68, those things still in some places took another 5, 10, 20 years before you actually saw the full effect of them. In 2008, we did have the first African-American that was elected to the presidency. At that point, we're about 20 generations in. And then in 2016, what we have seen since then is just been a spike in racial incidences globally. So this next slide, we talk about Black bodies and medical horror. So what we're talking about is what in those 401 years, and primarily from that 1619 to about 1960s, what did African Americans endure? We know they endured slavery, we know rape, we know lynching, but what did they endure on the medical side? So I just kind of pulled out a key piece. I actually read the book Medical Apartheid. If anybody is interested in that book, again, it's called Medical Apartheid. And I just pulled out some of the key references, but I'm telling you, it's much, much more than this. So I'll just go through a few of them. Like you had James Marion Sims. He was in the 1830s. He was actually from Lancaster, South Carolina. He went to medical school for about a year, but he's considered the father of modern gynecology. But the way that he did his research was on enslaved, it was on enslaved Africans. I typically do not like to use the term slave because they were not slave, they were humans that were enslaved. So I definitely like to make that distinction. But he was considered the father of gynecology. And again, all of his research were done on enslaved women, and he did not use any type of anesthetic. He did not do any of that, any of those things. And actually, for those women that go to the doctor now, the equipment that they're used, he developed that then, and it was, again, developed because of his experimentation on slaves. 1831, South Carolina Medical College. So they put out an ad because they were looking for medical students, and this is what their ad said: no place in the U.S. offers as great opportunities for the acquisition of anatomical knowledge, subjects being obtained from among the colored population in sufficient numbers for every purpose and proper dissection carried on without offending any individuals in our community. You had P.T. Barnum. Yes, that's Barnum and Bailey. He kind of got his start by, there was a slave that died, and he hosted a public dissection and sold tickets to the dissection. He actually sold 1,500 tickets. And that is kind of how he got his start. And after that, it was the display of African Americans with vitiligo. So they had the medical condition. That is where you have the lightening of skin, where they will actually look white. And he termed them white Negroes. So he kind of put them on display. I put the 1840 census here because in that census, when they did the census, in this particular, you had some free, what they call free Blacks. And what they said in this census was they were trying to justify that African Americans should be enslaved because they said the ones that were free were sicker. And so that they needed to be enslaved to actually be well. That was their excuse behind that. I put North Carolina Mutual Life Insurance. I put 1858 because at that point, they had 75% of slaves were insured by their owners. You have the Medical College of Georgia. They had stole African-American bodies to do experimentation on. You had Dr. Harry J. Hazelden. He was kind of important because this is where you start to get into eugenics and where you start to get into to say, what is the better race? What is the race that is superior? This is where you start getting into the point where they said some people should not live. And this actually spread. It actually spread to Germany, and that's why you got your rise of Hitler. And again, Dr. Harry J. Hazelden here in the US, he actually put an ad out in the paper, and he talked about how he would kill some slaves' children because he did not feel they were fit to live. And again, you see right around that time, here come Margaret Sanger with the Negro Project. Her thing was actually birth control to keep Black women from having children. You have the Tuskegee syphilis experiment that was 1932 to 1972. And because of that, we actually ended up getting the law. It's the national, excuse me, let me get it here. It is the National Research Law. It was signed into law in 1974 that basically said that you cannot experiment without people's consent. So anybody that was going to be in a research study, you had to get their consent. Henrietta Lacks, she was 1950s. I'm not sure if you've heard of HeLa cells, but HeLa cells have been the basis for all of your cancer research since that time. It was also instrumental in creating the polio vaccine. Her family did not find out until the latter part of the 2000s, and as of yet, they still have not been compensated for that. I put Thomas Merrill on here because he was actually a public health service physician. He worked for the government. And in the 1940s, he said, the future of Negro lies more in the research laboratory than in the schools. When diseased, he should be registered and forced to take treatment before he offers his diseased mind and body on the altar of academic and professional education. Harry Bailey, 1960, he's a neurosurgeon. He stated in his 1960 speech at Tulane Medical School, this is his exact quote, "It was cheaper to use ends than cats because they were everywhere and cheap experimental animals." And then the University of Cincinnati, they had a contract with the Department of Defense where they actually performed radiation experiments on poor Blacks. So those are just some of the highlights that I pulled out. Also too, I just wanna make this clarification to Dr. Harry J. Hazelden and Margaret Sanger, that was actually the 1830s and 1839. I apologize for that. So we see all of the things that happen, and that's just some of the incidences with African Americans in the medical field. But the Richmond Daily Dispatch, which is a magazine, it was a newspaper article they put out, and they said among them, they were talking about Blacks, there prevails a superstition that when they enter the medical college, they never come out alive, although nowhere are they better treated. And I put this in here because it goes to tell you what the mindset of African Americans were at that time. The horror, the terror, what they thought, but it also kind of gives you some insight into what the thinking of those that were free men. So they felt that it was a superstition. And they also thought that the slaves were treated better by being experimented on than they were if they were free. So we kind of get into the psychology of how people think, and then sometimes what some people call cognitive dissonance. I typically do not use the term white supremacy. I know some people use that term. I typically don't use that term. I like to use the term deliberate systems of inequities. The reason why I do use that term is because a lot of times I feel that with our education, when you think white supremacy, we often think civil rights movement, we often think overt racism, we often think the N-word, we think Bull Connor, we think the screaming, individuals, we think hose pipes, dogs, bombs. That's just kind of what we think. And I think that personally distorts our perception of racism, inequality, and systemic oppression. It makes us think that it has to be overt. It makes us think that it has to be nasty. And also, too, it does not give way to how these systems tend to work together to suppress a group of people and actually keep them marginalized. So when you talk about deliberate systems and inequities, I talk about education, economics, media, law, health, media, labor, health, law, politics, and religion. And if you think about the slide, the reason why I put those particular examples, I'll go back here. The reason why I put those particular examples here, because in all of these examples, you can see almost all of those systems play out. You can see labor as far as, and of course, slavery wasn't labor, but if you think about it in that way, one of the reasons for slavery was economics. You see the government here, right? We talked about a Department of Defense contract. You see how they use newspapers to put out articles. So now you're talking about media. You see how the colleges, so you got the Medical College of Georgia, the University of Cincinnati, Tuskegee. So you have your education in there, your universities, how they were used. You have the 1840 census. Again, you have government there, and you have media, which some people call entertainment, where you have P.T. Barnum. So we have to understand how all of these systems work together, because they do tend to work together to marginalize groups. Social determinants of health. What are social determinants of health? They're conditions in the environment in which people are born to live, work, play, worship, and age that affect a wide range of health, functioning, quality of life, and health risks. And then here you have economics, neighborhood and physical environment, education, food, community and social context, and healthcare systems. And again, the list that we just talked about, you can see some of those things play out here. So I just kind of went back about 60, 70 years, and let's talk about some of the recent social determinants of health. I put the civil rights movement, that stress, the war on drugs, the 2008 recession, because we have to understand that economics plays into healthcare. If you don't have a job, a lot of times you don't have healthcare. Police brutality, and then now COVID-19. What are some of the health disparities African Americans have? So we're talking about stroke, breast cancer, cervical cancer, prostate cancer, HIV, which is a virus as well, diabetes, maternal mortality, obesity, heart disease, and asthma. So those are a lot of the health disparities you see in African Americans. So what is COVID-19? So COVID-19 is a novel. When you hear them say novel virus, that means new. That belongs to the family of coronaviruses. A lot of people say, oh, well, it's the 19th virus. Actually, when it says COVID-19, what the 19 means is the year. So it happened in 2019. It is known as the severe acute respiratory syndrome coronavirus and has caused a worldwide pandemic of respiratory illness and deaths. It supposedly started in the markets in Wuhan, China. The first case in the US was on January 21st, and we had the first death on the 29th. And these numbers are up to date. I just looked them up about a couple hours ago. So if you see globally, it's 8.2 million infections, and the US has a fourth of those infections. Deaths is 446, and again, the US is almost comprised a fourth of those deaths. What are the symptoms? Chills, repeated shaking with chills, muscle pain, headache, sore throat, new loss of taste or smell, fever, cough, shortness of breath, and difficulty breathing. The issue is a lot of people can't tell what's COVID, what's common cold, what's flu, and what's allergies. And that's why they'll tell people, if you have any symptoms, if you feel like you're sick, just stay home. But this is just kind of a nice little chart to kind of tell you what is common, what's sometimes, and what's rare with COVID versus common cold, flu, and allergies. The issue is a lot of them do overlap though. So this is just some of the key points with COVID. Is novel, meaning it's new, and we do not have a vaccine. That is why we're seeing the spike in infections the way we do. There's been a lot of confusion around COVID. What is it? What should we be doing? Socially distancing? Should we wear masks? Should we not wear masks? And I think all of us kind of heard a lot of that play out, especially in the first crucial months of this virus. Science, unfortunately, is not at the forefront. It's implicit bias that affected policy and decision making. So this is why I say this. When they ended up looking at data, and this is why data is important. So when the coronavirus first came out, it said, okay, it came from Wuhan, China. So it was, we're gonna close off the airports. So no one can come in and no one can come out. Now that didn't quite work like that, but that was the policy. So if you were from China, you were not supposed to be able to come into the country. Well, when they looked at it, you had an East Coast coronavirus and you had a West Coast coronavirus. The coronavirus started on the West Coast, but that was a much milder form in comparison to what came to New York. So the coronavirus that was on the West Coast, that was from China. The coronavirus on the East Coast in New York actually came from Europe. So that was the different strain. So while the focus was on China and cutting off travelers from China, you were letting European travelers come in and they were bringing the virus. And actually they were bringing a more deadly virus than the one that was already here. You had a lot of inequality in testing initially. I know I worked in healthcare. I was trying to figure out how and all these stars getting tested and us in healthcare are not getting tested. And there still remains a lag in testing. One of the things that I was really concerned about with this virus is it replicates very similar to HIV. So when I first heard about the virus, all my bells started going off. I said, okay, this is a very dangerous virus because it replicates similar to HIV. And as medical providers, we should always be thinking that way. Okay, how does HIV work? Well, I had put out a Facebook post because I'm like, well, this thing, if it replicates similar to HIV and it is an RNA virus, it's probably going to work like HIV. So what does that mean? That means it's going to be highly contagious and infectious. So if you're familiar with HIV is most infectious during its replication stage, meaning the first couple months after you're infected with HIV. The problem is that's when you don't have any symptoms. You're considered asymptomatic. So you're spreading it and not knowing that you have it, but then that's when you're the most contagious. So my concern was, okay, we're going to have what we call asymptomatic carriers. We're going to have people shedding this virus. They are not going to have any symptoms. They're not going to know. And then this is why this virus is going to spread. And I'll be probably about 3-4 weeks later after I made that post, they did come out and say, okay, we're worried about asymptomatic carriers. Another thing you have to think with HIV too is what I call the leave behind. It's a virus, right? So just like when you get chickenpox when you're young, and then when you get older, you get shingles. Because viruses tend not to go away. Sometimes they can lay dormant in the system. So my mind has always been thinking, is there going to be a leave behind? I honestly think this is why they're doing antibody testing, because if you really think about it, SARS and MERS, all of those were novel as well, but they did not do any antibody testing, and there hasn't been the focus on those viruses the way that there has been on coronavirus. So it's just something to keep in mind. There is varied testing, and there's no definitive gold standard. So what we do at my facility, LabCorp may be doing something different. They have not laid out a definitive gold standard for how you do testing. It's more deadly in the elderly, those with chronic disease, and communities of color. Another big issue with this virus is, again, it's the asymptomatic carrying, and it's the time that people either do not have symptoms at all, or the fact that sometimes it can take 2 to 4 weeks before symptoms show. So when that happens, that's why you always have a 2 to 4 week lag time when you're assessing spread. So the reason why cases are spiking now is because of what happened with Memorial Day. And of course, now the protests, I know people are saying, oh, these are from the protests. No, we haven't seen the spike in the protests yet. The spike that we're seeing now is Memorial Day. We'll probably see the spike in the protest in another week or two. of course, the recession, and there's been a total lifestyle change. I mean, you know, if this had been any other time, I probably would be on campus giving this this lecture, but of course, we're having to do Zoom. Also, too, they opened up the economy about a month before scientists recommended. So the recommendation was to keep the economy closed for an additional month, so not open the economy up into June. And then they thought at that particular point in time, you would have the disease under control, and then that you could control outbreaks, but we did not do that. Your essential workers are primarily people of color and are poor. That kind of leads to disparities. And again, I talked about that, the spike in cases across the US in the past 2 weeks, Memorial Day and the protests. And that's what you're gonna see here coming up. It doesn't matter what statistics you're looking at in the US, when you're talking about COVID-19 and racial disparity, you're always gonna have a lower percent of the population and a higher percentage of deaths. This information is recent, it's from June. So this is the aggregate deaths from COVID-19 across all states in the District of Columbia. So if you're African American, you have 61.6 deaths per 100,000. So it's 2.3 times higher than, because we're always typically compared to white Americans than white Americans. So what that means is if the current health disparities did not exist, there would be 14,400 Black Americans, 1,200 Latino Americans, and 200 Indigenous people still alive today. Collectively, Black Americans represent 12.4% of the population, but they have suffered 24.3% of the known deaths. So we're dying at twice our population share. Reversing the trend. One is going to be knowing that COVID-19 is real. There's a lot of misinformation about, you know, is COVID real? Is it a conspiracy theory? You know, it's asymptomatic. I'm young, so I'm not going to get it. I don't have chronic disease, so I'm not going to get it. It's just a lot of misinformation, and we have got to get some of this misinformation out of the way. You need to really wash your hands, wear a mask. People are not wearing masks like they used to. If you're out, I'm pretty sure people are noticing that. Socially distance at least 6 feet, avoid touching your face, stay home if you're sick, covering your mouth. So these are some of the things that we have already heard on the news. Manage your chronic conditions. That will be the thing that I would add. Get tested if you have been exposed, and quarantined. There have been a lot of people that know that they've been exposed to someone and or know that they have COVID and still will go to work, because we're talking about economics. People have to pay their bills and have parties or go to parties, because now you're talking about social isolation. And that was one of the psychological things that I was worried about with COVID, because you see it with HIV. So if you think about it psychologically, no one wants to carry stigma. So we talk about stigma. Nobody wants to be the it. And so when you think about COVID-19, because of it's asymptomatic, it's a very scary disease. People have to work. And it just puts them in situations where they're either going to go to work sick because they have bills to pay. They don't want people to know because they don't want the stigma. And they don't want people to know because they don't really want to have to quarantine for 14 days. So it kind of puts us in a pickle. And that's kind of what you see with HIV too in some ways. Now, I just want to touch on this. And the reason why I want to touch on this is because when we talk about health disparities, we have to ask ourselves again, we've been talking about health disparities since 1619 in this country. And I always make this comparison because we really have to think about this. So why do health disparities still persist? Because can something be done about it or not? And so we have to ask ourselves. And one of the things that I presented on was the heroin epidemic a couple of years ago. And so this is something that I've been tracking for the last couple of years. And so as I've thought about it, I've said, okay, I haven't seen anyone march and I haven't seen anyone protest to change what happened with the heroin epidemic. So what happened with the heroin epidemic? So within the last 10 years, you've had a spike in heroin use in mostly rural whites and what we call suburban, so rich, middle class, upper middle class whites. That started happening approximately 10 years ago, and it spiked about 5 years ago. So now we're looking at, so what's the spike? How many deaths are we talking? Anywhere from 30,000 deaths to about 60,000 deaths. So we have to think that is less than we've seen with COVID, because right now with COVID, we're at 17,000 deaths. But the point that they got to about 30 to 60,000 deaths a year, it became an epidemic. That's how it was named. That's how it was talked about. Now, when I talk about deliberate systems of inequities, and you talk about systemic oppression, again, we talk about how systems work together to marginalize groups. Now, those of us are familiar with the war on drugs. The war on drugs started in the 1980s, and it has persisted, and I mean persisted even to this day. But what happened about 5 years ago, a carve-out was made for heroin. So what does that mean, right? So when the war on drugs started, it involved several different groups, areas, law, politics, policing. But what we have seen is we've seen a change with the heroin epidemic, and it is because of who it impacts. We've seen a change on political level. So we've had legislation, we've had 2 pieces of legislation, each about $1 billion putting out money for the heroin epidemic. We've seen changes in our laws, right? So before it was lock them up, throw away the key, 3 strikes and you're out. If you go to some areas, there have been carve-outs for heroin. So if you're a heroin user, and I know they use the term opioids, but heroin is an opioid, then it's mental health treatment, drop them off at mental health, drop them off at the hospital, but don't arrest them. Don't put them in the judicial system. Healthcare, what has been the changes there? So we've gotten education, is do not create a stigma, quote unquote, no name calling. Now, those of us can remember crackhead. Those of us can also remember crack baby. But in this situation, it's not talked about like that. I mean, there are actual talks that are going on and telling people, do not stigmatize the mothers, do not make them feel bad, do not call now these are babies, do not call them by names, and you shouldn't call them by names. But what I'm talking about this to say that we have seen a wholesale change in the way that we treat heroin epidemics. We've seen a change in mental health. We've seen a change in substance abuse treatments. We've seen more money and more focus be put there. We've seen changes on the local, state, and federal level. We've seen changes with pharmaceutical companies. Used to be a point, if you wanted Narcan, you had to be coding in the hospital. Now Narcan is sold over the counter at CVS. We've seen a change in language. We've seen TV specials that are actually empathize and sympathize with heroin users. We've seen a change in the insurance industry, right? So it used to be if you died of a drug overdose that was not covered under insurance. Well, that was changed for heroin. And so then that's why it's now called accidental overdose. They did not mean to overdose, because now we still need to get a payout on insurance. The war on drugs still remains, but again, there's a carve out for heroin. And we have not seen the aggressive policing with heroin in middle and upper class communities or in rural that we have seen in communities of color. So I put this up here because, again, when we talk about deliberate systems and inequities, we're talking about just about every system I talked about. All of these systems have changed. Money has been provided, education has went out, language has changed, behavior has changed, all to make sure that those that are affected by heroin they're not stigmatized, they're not in prison the way that those with crack cocaine, because remember, we just had a fight about crack cocaine because it was 100-1 sentence of disparity, and we were able to get it down to 18-1, but there's still a disparity. But now if you're heroin, what they'll do is they'll bring you in this treatment, probation treatment, and then if you're a repeat offender, then you're looking at prison. So we have to ask ourselves, how could all of this have changed in 5 years when we can't get any changes on whether it's police brutality, whether it's crack cocaine, whether it's health disparities? And I say that to say that we have to understand that there are people behind these systems that are not moving in the way that they should because it's not impacting people they necessarily care about. Thank you.
All right, thank you so much, Dr. Anderson. Now I want to open up to our participants. So like we have done in the past, if you have any questions, comments, reflections, just type your name in the chat, and then I'll call on you. Any questions, reactions, anything like that? Dr. Norwood. Dawn?
Sorry about that. My
Okay.
mute was on. Apologies. Thank you for sharing all that information. It was really, really on point, and I like really how you brought everything together and show how all of our major systems in our society, education, medical, all of those systems work together to create these disparities that we see now. And my question for you regarding COVID, especially as it's hitting the communities of color the hardest, just kind of your thoughts in general, or what your suggestions may be as a medical professional. What do you say to those of us who are watching the news? We're watching different sources, and we're getting a lot of conflicting information that comes out of, say, the White House in 45, than we do from the health professionals. What are we supposed to, and who are we supposed to be listening to in terms of best practices, where this thing is going, what we should actually be doing to keep ourselves safe? If medical professionals are saying one thing, but then you have the White House administration in 45 seemingly saying things that are opposite of what has been put out there. And how dangerous is that also to everybody?
Thank you, Dr. Norwood, for your question. You are absolutely right. I did briefly touch on that because there has been a huge amount of confusion, and I myself was concerned about that, and that's why I ended up making my Facebook post. It was like the first week of March, because I was like, this is just too much confusion. You know, I'll tell people, and it's true. So chaos and confusion is a tactic. We have to know that, and we have to understand that. So sometimes things can seem confusing and chaotic, but that's actually a tactic, right? Because nothing can really move when you have a lot of confusion and chaos, because as you said, people are confused and they say, who do you look like? I mean, who do you listen to? So one of the things that I know I had to combat early on was, one of the things that was said was, it was like the flu. And so this is what I mean when I talk about deliberate systems of inequity. So media is one of those systems that are used, right? And the reason why we know that is because we can talk about headlines and how headlines are written. And so when we're talking about language and media, we have to remember what the mind sees and hears, it remembers the most, especially when you're talking about psychologically. So that whole, it's like the flu, that went on for a month. I cannot tell you how many people I had to say, this is not the flu. Is it similar to the flu? Yes. And I'll be honest with you, is it a respiratory virus? Is it not a respiratory virus? Because this is the thing. So HIV presents with respiratory symptoms. So to me, when I look at coronavirus, until there's more research, because we're only 3 months into this, maybe 4 at the most. I just know it's an RNA virus. That's how I look at it. Because again, HIV is an RNA virus, and when people present to us, they present with flu-like symptoms, because that's sometimes what RNA viruses can do. And I don't mean to say that to sow any type of confusion, because I'm not trying to do that. I say that to say that we're 3 to 4 months into this thing, and we need a lot more research. I do think that misinformation is dangerous. It is very dangerous to marginalized communities. It's dangerous to everyone, actually, right? Because we're also seeing a lot of misinformation about masks. So that is another thing that has been confusing, because you have one part of the government saying no mask and refusing to wear a mask, and then you have another part of the government saying that masks are important. And so when you get those conflicting informations, and people want to believe who they want to believe, then you start to see those patterns of behavior. Now, one thing I say is, and I had to post this the other day, Dr. Fauci said at the end of April, if we open up too soon, we're going to see a spike in cases. He said that. You can go and research. He did several interviews. He even testified on Capitol Hill. He said, we are opening too soon. And if we do it, we're going to see a spike in cases. And what the data has shown us is that we're seeing a spike in cases from Memorial Day. And again, the protest spikes are not quite here yet. They're coming, but they're not quite here yet, because it hasn't really been enough time. So to me, I have to go with the person that has said, has been consistent since the beginning, and what they have said has come to pass. So there's nothing that Dr. Fauci has said that has not come true. So I say listen to the experts, and I get my information from Dr. Fauci and the CDC.
All right, thank you. Now we have Allison, and after that, Dr. Monday.
Dr. Anderson, thank you so much for your presentation. I just had a question, more of a follow-up question to Dawn's question, I think. And also thinking about misinformation, I wondered if you could list out the chronic conditions that you think of people that should be most concerned about their chronic or at-risk conditions, because I think that there's some misinformation about who should be concerned, who shouldn't be concerned, who have chronic conditions as well.
Okay, so any respiratory condition is definitely, because one thing about COVID is it does attack the lungs. So asthma, COPD, any type of respiratory condition that you have, chronic bronchitis, those individuals should definitely be careful. If you have an autoimmune disorder, because when you have an autoimmune disorder, a lot of times you're on medicine that suppresses, right, your immune system. Those individuals have to be very, very careful. Cardiac disease, so any type of heart disease, so previous heart attack, congestive heart failure. If you have high cholesterol, because that puts you at risk for a heart attack. So because when COVID operates, it attacks the lungs. Well, when you attack the lungs, you weaken the heart. And so that is why when you saw so many deaths from COVID, you saw what we call ARDS, which is acute respiratory distress syndrome, or you seeing heart attacks. And that's because those systems work so intricately together that almost sometimes when one fails, the other fails. So any cardiac conditions, any high blood pressure. The reason why high blood pressure is important because it affects the heart. And also too, high blood pressure can put you at risk for stroke. And that's another condition that we saw. And it's likely because the virus was putting such a strain on the lungs and the heart that we saw stroke. But it's also a virus, so it was causing people to throw clots. So it was causing the blood to aggregate. So I think those are some of the most important chronic conditions that people should be, if they have those chronic conditions, they should be very, very careful in this environment.
Thank you.
You're welcome.
Dr. Monday.
Hello?
Yes.
All righty. So I have a two-part question. The first question I wanted to ask had to do with how do we identify signs of discrimination within medicine? So right around 2 weeks or so after the lockdown went into implementation in New York City, there was footage of discriminatory policing of social distancing rules in communities of color in the Bronx, for example, compared to primarily white communities in places like the Upper West Side. And I wonder how can someone in a community that has historically been marginalized be aware of possible signs of discrimination within medical establishment, you know, having symptoms taken seriously, making sure that they're receiving testing. And then the second part of my question is about protests. I was listening to an interview with Dr. Fauci, I think just this week, maybe Monday, and the question was raised to him about protests and whether or not people should protest. And he was very careful in hedging his, you know, the way he hedged his response, because he didn't want to say, no, people shouldn't protest, but also recognizing the risk. What has been your personal take on protests, given that what people are protesting have to do with some of these core issues that you mentioned in discrimination, but of course, keeping in mind our present health situation?
Okay, so the first question, wait a minute, so Lord, I'm sorry, let me answer the second question with protests. So as far as protests, there has, I'll be honest, I am a little conflicted about that, just because I myself belong to a marginalized group, but at the same time, I'm a healthcare provider too. So we do know that we should be avoiding large crowds because you increase the risk of spreading the virus. And those were very, very large groups. You had a lot of yelling. You had a lot of people that were just grouped together, just too close. But then you also, I've heard the argument where people say, well, listen, we're dying anyway. So, you know, how do you weigh that, honestly? If you, from a medical standpoint, I say, well, you shouldn't protest because we're going to spread the virus. And we think that we've seen what Memorial Day has done. I can't imagine what the spike in cases is going to look like from the protests. But then I also understand that there are some individuals who feel that they have had enough and they feel like their only redress is protests. So I'll be honest, I'm personally conflicted on that, but as a medical professional, I'll always say safety first. And I'm sorry, what was your first question again? That's why I had.
So my first question had to do with the ability of folks, especially from communities of color, recognizing discrimination. I kind of drew the parallel between discriminatory policing of social distancing early on in New York City between communities of color and predominantly white communities. So when it comes to receiving treatment or requesting testing, are there key signs that someone may be able to identify that they're being discriminated against? So they know that based on what they're providing in terms of information, they should be testing, but maybe the provider they're interacting with is downplaying their symptoms, for example.
Okay, I do. Okay, so before COVID, there was discrimination in healthcare. It was there, it was present, it showed up in every statistic. So discrimination was already there. One of the things I was concerned about, and they did write a couple articles about, is that what does a healthcare system that is rooted in anti-Blackness does when resources become limited? Because that's really the question, right? Because what we know is historically what happens is when resources are limited, marginalized groups either do not receive or they get crumbs. And so if you recall, when you first think about COVID testing, the only people that were getting tested initially were those that were well off. So that wasn't really about race because you had people of color that were well off. See, now we're talking about a class issue because class always goes with race too. So when we're going into these healthcare systems that are already rooted in anti-Blackness, and you're talking about limited resources, then the question becomes, is it a lot of anti-Blackness? Is it limited resources, or is it both? And so I'll give you an example. because of the way that, so I'm not sure how many people are familiar, but we got to a point where we were just trying to source what we call PPE, personal protective equipment. And we were trying to source it from anywhere we could. Because what happened was, while coronavirus was spiking in China, and even while it had reached the borders of the US, we were still sending PPE overseas. So I was a little concerned when I did hear the president say that the cupboards were bare, because a week or two prior to that, he sent 18 tons of PPE to China. So he obliterated our PPE supply. And then he turned around and said it was because we didn't have anything. So we were dealing with conflicting information. Again, that can be researched, it's out there, people have talked about it. Well, then at that particular point in time, then you had private companies trying to get PPE from anywhere they could. That meant overseas. Do we have any manufacturers here? Who? Well, then you had a process where the federal government kind of got in the mix of that, and was also too going, and when people would get deliveries of PPE, they were going and taking it from the hospitals. So if you remember, the governor of Maryland, Larry Hogan, he had to get his supplies flown in at night under the radar of the federal government because he was afraid that they would come and take it. The federal government would come and take it, and then they would distribute it how they wanted to. So that is another reason why Governor Cuomo got together with the other hospitals in his area and said that we need to work together, because we were working against each other. So you had a supply, well, you had a demand, and then you had somebody controlling the supply that in some ways were worried about profit. And anytime you put profit in the mix of healthcare and a pandemic, you always get a disaster. So you had some organizations, like my organization in particular, we did not have any PPE. So you actually saw WHO and CDC make recommendations based off the fact that just nowhere in the world, especially US, had PPE. So now we're altering science to match supply and demand. And anytime you do any of those things, it is a very dangerous mix. So when a person goes into an organization, is it because they just don't simply have the supplies, so they're not testing them? Or is it because they don't believe them and it's rooted into anti-Blackness? And I think it could be a mixture of both. But I think that if you are symptomatic, then there are a number of sites that do testing for symptoms. Atrium Health is one of them. They test about 3 to 5 times a week. And you can go get tested. They're still not doing a lot of testing for those individuals that are asymptomatic. But if you are symptomatic and you have symptoms, then you should be able to get a test.
Judy?
Hello?
Yes.
Okay. Thank you for your presentation. My question stems from a recent thing that I saw on Twitter where Wingate students, particularly minority, and then just students in general, were sharing their negative experiences with our health centers. So my question was, what can institutions do to minimize, prevent racial disparities in the healthcare system, if that makes sense?
So yes, and so again, we're talking about systems and we're talking about structures. And that is why I say the slide I did for last, which was the heroin epidemic. Because that slide, and it had a very distinct purpose, and what it was to show was that when systems want to move, because they want to prevent death, they want to save, they are looking out for future generations. Because if you go back and you look at just the last 5 years of some of the language that was used with the heroin epidemic, it was, we can't allow these future generations to end up like this. We can't jail is not the answer. Treatment is the language changed, but that was because the people that control the levels of power wanted it to. So we have I'm not sure if you guys have seen, it was a recent article, a lady, she worked at one of the mutual funds. She was the head of diversity and inclusion, and she lost her job in December. And one of the things that she said that she would always have to go back and forth with upper management was about increasing diversity. And they hired her for diversity and inclusion, but they didn't really want any teeth to the program. So sometimes what happened is we have diversity and inclusion programs, but they have no teeth. And so that is how you use systems, right, to marginalize, because what I can do is I can give you the appearance of power, but then when I write the rules and the regulations, so now we're talking about politics, law, regulations, then I can take the teeth out of it. So then it's there, but it has no power. And so until these systems move, and so I'm the type of person, I say change is not needed, transformation is. Because we have to get in here and we have to change systems. And that's going to require removing people that do not see themselves as contributing to a system, but they are. And so we have to be, you have to kind of be careful with how that's done, but at the same time, it definitely needs to be done. And until people wake up, be honest about what has happened in this country, have some true reconciliation about it, then all you're going to be doing is spinning your wheels. The question that we really have to ask ourselves is, that's what people want us to do, because the question I have to ask is, how many protests, how many, you know, whether it was protests, marching, did anyone see when it came to the heroin epidemic? How many? Because the issue was people were dying. Now, the difference in the issue is, let's be honest, police brutality, I'm running into someone and they're taking my life for something that honestly, if I was to go to court for, they wouldn't execute me for that. But when you're talking about heroin, now you're talking about somebody making a decision, even if they're sick, because they are sick, and I'm not saying they don't need help, but it is a decision to inject drugs that you know, right, can cause death. And so when I'm talking to some of those heroin users, they're using drugs and they have the Narcan right there when they're using, so that if anybody passes out, then you can give Narcan. And so that didn't just happen because it just happened. That happened because systems moved. Because again, I've been in healthcare for 21 years. And it wasn't until 5 years ago that you could get Narcan at CVS. These systems moved so much that in Pennsylvania and Philadelphia, they were actually talking about trying to open an injection center. This was a center that was going to be staffed with nurses. It was going to be funded with donations. And so those people could bring their illegal drugs into the injection center, use illegal drugs. If they passed out or almost died, then it would be somebody there to give them Narcan to save their life. That has never happened and never been proposed in a war on drugs until 5 years ago. So we have to ask ourselves, where is the teeth to this legislation? Where is the teeth to diversity and inclusion? And why are systems not changing? Because when they want to change, they do.
Thank you. Alex.
Hi, my name is Alex. I'm a rising P2 pharmacy student at Wingate. And my question for you is sort of, how can we stay informed about some of the things that are going on? And not only stay informed, but I know that I really haven't been educated on a lot of the history that you presented at the beginning. So what sort of resources do you recommend for a lot of education as far as the history of how we kind of got here with income and not a lot of access to healthcare for those lower income households?
So again, Medical Apartheid, that book was really good. It was very eye-opening to me. Another one that's good where it gets into the psychology is called Post-Traumatic Slave Syndrome. That's a really good book too. She kind of goes into the psychology of some things. That's by Dr. Joyce DeGruy, but she also talks about healthcare. I also think that if you kind of just read the history of the civil rights movement, that will help too. Like, how were ghettos formed? Why were they formed? A lot of your ghettos ran through what a lot of people call, quote unquote, Black Wall Streets, or well-to-do Black areas. The ghettos just were formed and ran right through those areas. Right. And again, this is why I talk about systems, because that was a decision that was made. A political decision was made, money and resources were put in it, and then they pretty much ran over communities of color. And we see that again with gentrification right now, correct? So gentrification, the reason why we saw it sped up is because of opportunity zones. Opportunity zones were created on the federal level, and that money has been shoveled down to the state and the local governments. So we really have to start understanding how local, state, federal works together, how education works together, right? So if you are only getting a partial education, and most of your education, you truly believe that there's a pathology to a certain demographic of people, because you have not gotten the totality of the information that you need, then your information, your decisions, your reactions are based off of that limited information that you have. And there's a pathology, because if we really look at it, there's a lot of anti-Blackness, and it's because people feel that Black people are inherently bad, right? And then you'll hear these conversations in this black and white. Well, they don't do this. They act like animals. They, like, if you just go and read some of the language, even with the protests, you'll see some of that language. Now, when you start talking about what some people call white supremacy, I call deliberate systems of inequity, you start getting into a good and bad situation. You start a good and bad dynamic. Well, they're good people. They're not racist. If you go and listen to the language of the heroin epidemic, it's not their fault. It was us as healthcare providers. We prescribed too many narcotics. It was the drug dealers that was bringing the drugs from Mexico. And I think one time somebody said they were bringing them in from New York. And I know, like, I run in a lot of political circles, and there's an affluent neighborhood not far from me. And it's going through a rash of break-ins, because one thing that's not really talked about on the news when it comes to this heroin epidemic is the rise in crime that has happened in those affluent neighborhoods. But there's a lot of break-ins, there's a lot of drugs in the high schools. So those things are not being talked about. Police are not in those neighborhoods policing to the effect that they were in Black and brown communities. And it's because there is a perception and a mindset that this is not their fault and they need help. So we have to start breaking those dynamics. We have to start understanding history. It's a lot. I don't know it all myself. I'm still learning. But the more knowledge I gain, the more it helps me to really look at situations differently and understand that we did not just get to 2020 5 years ago. We got to 2020 401 years ago.
Thank you. So I also have a follow-up question about that in regards to legislation. What would you say needs to change, or what sort of bill would you say needed to be introduced and passed in order to change that dynamic?
So I'm an objective person, and I love data, because you can't really argue with numbers. Now, you can manipulate numbers, but you can't necessarily argue with numbers. So when I was in management, before I went back to get my MP, one thing that I would do is, because I felt like I was marginalized, I would say, okay, we're going to give out raises, right? But we want them to be fair. So what I would do is I would create a system, and it was based off objective data you couldn't argue with. I didn't give it to it because they were my friend. So we can start using objective data to change systems if we wanted to. So the question becomes, what I'll hear people say is, well, we don't want to give anybody a job because they're Black. I can in some ways agree with that, but then what about the 350 years that we only gave jobs because people were white? Nobody talks about that, right? And if you look at the way jobs have went, so in the 70s, they told us that we needed experience, right? Because they know we didn't have any, we were coming out of the civil rights movement. Then it went from experience to we needed education. Well, they knew that we were just kind of getting over the hill. A few of us had education, but it wasn't there. So then it was you needed education. Well, as soon as people started getting the education that they needed, it changed to education and experience, right? You started seeing that, you started seeing those requirements. Then now, I'm not sure if anybody is used to or heard this lingo, the right fit. So education doesn't matter anymore. Experience doesn't matter because now we're looking for the right fit. So what does that mean? And this is when I say how language gets thrown into systems and can keep them going, because we went from education to experience to education and experience to the right fit. Now I know what the right fit means. You ask any Black person, we know what the right fit means. But the question is, why was that started? Who started that? Where did it come from? Why was it started? Those are the questions that we have to ask ourselves. Why does language get injected into conversations to change how we look at things? How important is language to the systems of deliberate inequities? Because to me, I think it's very important. And so we have to make sure that when we do legislation, is objective and it has teeth to it. I don't have any particular, I'm not a policy person, so I don't particularly have anything that I could say. But one thing you can do, I mean, how many of us have probably sat on interview panels and we wanted one person and it's 10 of us that said, oh, we should go with this one person, but somehow the one person at the top made a decision and they decided on somebody else, right? How can HR say, well, when it comes to executive leadership, let's start doing survey monkeys, right? So if executive leadership doesn't want to know what the interview team said, what's the point? What's the point? So you're doing interview teams, well, why are you doing them? Because in that case, what you're doing is just going through the motions. So we have to have, at every turn, we have to have objective data and we have to have something that holds it accountable to make sure that we are injecting diversity and inclusion and we're not just going with who makes us comfortable.
Thank you. Anyone else? Any reflections, questions for Dr. Anderson? All right. Did I miss anyone? No? Okay, guess not. So Dr. Anderson, anything that you want to leave us with? You've been amazing with a bunch of just great information. So I guess anything you want to leave us with as we move on?
Well, I just want to say thank you guys. Thank you for listening to me. I know sometimes conversations like this can be very hard, but I can say moving forward, they are very needed. I think, like Allison said, we just have to get to the point, or one of the questions she asked, we really have to ask ourselves, how can we change systems, right? And changing systems, you can't just change systems, you have to change mindsets. And that's why I kind of get into the psychology. I didn't really talk about it here, but when you talk about the psychology of systems, one thing, if you listen to some of the cognitive dissonance that was going on in the 1830s, you hear it now in 2019. There was a physician in Congress that asked, did people of color get coronavirus because they were not washing their hands and they were living on top of each other? That question, that was posed by somebody that went to school for 8 years. We have to understand that education does not always confer intelligence. It doesn't. Education is a piece of paper, but we have to make sure that we're using data, we're using facts, we have to make sure that we're leading with love, and that we have to ask ourselves, would I want to be treated that way? Would I want my children to be treated that way? Do I really think that this group of people or that person is that bad because of the color of their skin that they do not deserve? And those are the hard questions that we have to ask ourselves, and we just have to remember to always lead with love.
I'm sorry, Dr. Anderson, that wasn't the last word. There's a couple more questions, feedback. There's Jesslyn.
Hi. So my question is, and also a little bit of background about myself. So I'm multiracial, half Black, half white, and I'm also chronically ill. When I was diagnosed a couple years ago, I was very fortunate to have been diagnosed quickly, but I know it's not the same for everyone. So does colorism have a huge effect as to why why Black women aren't always listened to, etc.?
Is it Jesslyn or Jesslyn?
Jesslyn.
Jesslyn, hey, how you doing? Thank you for your question. Do you mind if I ask you a question, because I can't see your face? So do you mind if I ask you a question? It may be a little sensitive,
Yeah. Yeah, sure, go ahead.
Oh, okay. So that's the question I was going to ask you. If I saw you, how would I identify you? Because you do have some people that even if they're mixed race, they still would fall into a category where some people may perceive them as more like me. And so when I hear you say that you had a diagnosis really fast, it could have been, honestly, it could have been the knowledge of the physician. It could have very well been that. I'm not the type of person that I believe everything is about race, because I tell you, good physicians and providers will save you a ton of money. And also too, they are good for your soul and your health. So it could have been just a really, really good physician. It could have been that maybe you were perceived as having more education or money, because I've seen that kind of factor into, right? How do we treat those that stumble into the ER that we perceive as homeless versus the woman that comes in with Gucci, and I know her husband is a top executive in Charlotte somewhere and may have some pull. You know, I'm not saying that's your case, but it's just so many factors into that. I think with Black women, I think honestly just with Black people in period, and I think that really a lecture needs to be done on that, because we talk about racism a lot, right? But what is racism? What does that really, really mean? Because you do have some groups that may not experience as much racism as others. And I really think the issue when you're talking about Black people is anti-Blackness. And we don't really talk about that to the manner that we should. And so I was on Twitter today, and there was a lady, she's an executive at Stars. And so the executive at Grey's Anatomy, she started the thread. And what she talked about was the fact that when she was younger, between the ages of 11 and 22, she had about 6 or 7 illegal things that she did. One was driving drunk, one was punching a guy. I mean, she just named all of these things that she did. And she said that every time a police was called, or they were not called, but when the police were called, she was always told, just go home, sleep it off, it's okay. And she said that she know for a fact that would have never been done with a person of color, ever. And another executive, the one at Stars, said that it was a writer that came into the room. The person was not Ivy League educated, and she did not code switch. And so what she meant by that is she didn't speak with what she felt like was the proper dialect. And because of that, she said she ignored her and she mistreated her. So see, that's when we were getting into anti-Blackness, anti-not me. And that's when that's tied up from 1619 until now. And it's just so many factors that goes into that. It's just kind of hard to say, is it all anti-Blackness? Is it the provider just is not aware? You know, is it that you had a really hard diagnosis? Maybe you didn't give me all the information, but we do know that there's an element of anti-Blackness there. And I think that just like with women anywhere, like they said, the most disrespected person on the planet is the Black woman, and that is the truth.
Josie Knowles? No. Oh, hold on, let me see. All right, I think that's it. Okay, so one final message, Dr. Anderson, whatever you want to leave us with.
No, I just think that my original message was what it was. I just think that we need to lead with love. I think that we are at a period of inflection in this country. I know people want the protest to stop. I do not think it is going to stop, as we have seen. I I do think that these companies, they're going to have to get it right. They can't be the Starbucks, which is to put out a public statement and say that we support XYZ, and then internally tell their employees that's not what we support, because that's what goes on a lot. And I think that you're going to see people continue to take a stand. I think you're going to see people continue to say that they're tired. It's check on your Black coworkers and friends, because this is a tough time for us. It's a lot of heartache, a lot of pain. Some of us just, we don't even know if it's left or right. I mean, 2020 has been hard on everybody, and we talk about race, but we don't talk about the mental part of 2020, right? The depression, the anxiety that's coming with 2020. I mean, our lives have literally been turned upside down. And I think in the face of that, all we have is each other. So we have to start having these hard, uncomfortable conversations. Those that like to be centered are going to have to start being comfortable not being centered. I would say that White Fragility is a really good book. Robin DiAngelo, she also has lectures on YouTube. I've listened to her. Sometimes it's really good to get her perspective, because as a white person, she's speaking directly to you. And it's up to you to listen, to say, okay, how do I do that soul searching? How do I ask myself, am I participating in this? And I think the biggest thing that we have to understand is that racism goes beyond the N word, and it goes beyond overtness, right? You can participate in it when you're on your job and you know a person of color is being mistreated, and you hear your boss or your coworker or whoever say something snide when it comes to race. You know they have an issue, because if it's about the job, race should never come up. So what are you doing in those instances? Are you challenging them? Are you talking to somebody in HR? Everybody has a private line they could call, or are you just going along with it because it doesn't affect you? And that's really the big issue. People are not doing anything because it does not affect them. So I ask people, because I did get a little frustrated, because again, like I said, I do run in political circles, because I was getting all these questions, but what should I do? What should I do? And I told them, and I'll be honest, the same thing you did with the heroin epidemic. And it's true, because you have to let us know as African Americans how that system changed in 5 years. It was entrenched. It affected just about every system: politics, law, policing, education, labor, voting. How was that changed in 5 years? Because we're at 401, and we have yet to see systems move in the manner that systems have moved for heroin. And so we need some help, right? Because police brutality, Trayvon Martin was 2012, it's 2020. So how did this system move without any protesting, without any marching, and without any fussing and what some people call cussing? I'm sorry, but I'm just gonna say, how, teach us that. Because that's what we need to know, because that's what we're trying to do. We're trying to get this system to move, because we don't want to be over policed. I have a Black son and a Black husband. I don't want every time they go out the door to say, Lord, are they going to come back? I did not let my son go to Virginia with his friend this past weekend, because I was afraid of him going through the back roads of North Carolina and Virginia and who he might encounter. And that's the honest to God truth. So if you can move if you can, not just a system, but systems, if you can get systems to move in 5 years, teach us, because we've been struggling for 401.
All right. On that note, thank you so much. Thank you everyone for joining us. Part 4 will be next Wednesday, and it will be the film screening of Ava DuVernay's 13th, which is about mass incarceration, and we'll have a discussion of that. So that'll be our final session of our racial injustice series. So thank you again, Dr. Anderson, for your powerful words and your powerful messages. We really appreciate it here at Wingate. And if you are looking for a Lyceum credit, please hold tight onto Zoom, and I'll put that link inside the chat box. Everyone have a good evening, and thank you again, Dr. Anderson.
Thank you.